over to you.
Thanks. Thanks ever so much, Noel. Apologies, Shemi couldn't make it today, so instead of a 5'10" man of Asian descent, you've got a 6'5" monster of Irish descent. Anyway, I'm delighted to be here to talk to you about the hidden epidemic of chronic kidney disease and also how we're kind of addressing that through some of the remote monitoring that we've been rolling out across the UK. So over the next 15 minutes or so, I hope to tell you a little bit about what chronic kidney disease actually is, the importance of an ACR test, the albumin to creatinine ratio test, understand a little bit more why patients don't routinely complete their ACR test, and then we'll come on to a case study from a national rollout where we are doing remote ACR testing, and we've got some interesting kind of data points that we thought were well worth sharing. So what is chronic kidney disease? Really, two key metrics here. The presence of kidney damage, mainly albuminuria, which is protein in the urine, so the leaking of protein into your urine, and or your decreased kidney function, so your EGFR, your estimated glomerular filtration rate. And so that would help indicate that you have chronic kidney disease. We're in the midst of a CKD epidemic at the moment. If you look at the global prevalence of CKD, it's risen by just under 90% over the last 30 years or so. And current projections estimate that it will go up by a further 17% over the next 7 to 10 years. So for us in the UK, in the NHS, that means that at the moment there are 3.6 million people with CKD. And in 2030, we can expect that to be somewhat in the region of 4.4 million. Unfortunately, 34% of those CKD cases are undiagnosed. So that means that as of today, there are around about 1.4 million people walking around with CKD that are not diagnosed. And CKD is asymptomatic, so they're completely unaware, and unless they're tested, they will not be aware that they have CKD. And typically, as with a number of other disease states, CKD is of greater prevalence in the underserved communities. So the most deprived suffer the most through CKD. Diagnosing and classifying CKD, we kind of look at two key tests, really. So one is a blood test, your EGFR, and the other is your urine test. And it's recommended as an annual test for both diabetes and for hypertension. But the reality is that clinicians tend to do the blood test, but actually the urine test, adherence to the urine test, is incredibly poor. The problem with that is that for the blood test, if you imagine the blood test is the rows across, you can see that if you get an EGFR and fall within a G1 or a G2 category, you could be assumed to be normal. No CKD, no worry at all. But if we layer on a urine test, an ACR result, and you fall into either an abnormal or high abnormal category, the A2 or the A3 categories, you can see that you start to fall into moderately or severely increased risk of CKD. So you need both tests to understand the real severity of CKD within the patient. Why is it important to understand that? Well, for every 100 patients with either moderate or severe CKD, we can expect the following. This is from the National Chronic Kidney Disease Audit, so we can expect 7 events of acute kidney injury, AKIs, per year, 6 cardiovascular events, 38 unplanned hospital admissions a year, 2 ICU admissions, and 7 deaths. If we can stop people from developing CKD, we can prevent death, and we can free up our front-end services as well. People with CKD have an elevated risk of cardiovascular disease, and cardiovascular disease is a national priority under the NHS long-term plan. Over the next 10 years, we're anticipating that 25% of people, particularly in the most deprived areas, will suffer a premature death as a result of cardiovascular disease. That's why the ambition within the NHS long-term plan is to prevent 150,000 strokes, heart attacks, and cases of dementia over the next decade alone. So there is a clear link between CKD and CVD. CKD is a stronger risk factor for all cardiovascular events than diabetes as well. So this diagram here from Foley shows that if you have CKD, which are the blue columns on the right-hand side, you are at much greater increased risk of suffering one of those cardiovascular events, a coronary heart failure, an acute myocardial infarction, or a TIA, and so on and so forth. So CKD and the link between CVD is incredibly, incredibly clear. Albuminuria is also a strong independent risk factor of CVD. So here what we've got is a paper from the Kidney Disease Improving Global Outcomes group, so the KDIGO group, internationally respected body. And what they've done here is they've taken a cohort with the same EGFR, but then categorized against their ACR results, so the level of albuminuria that they have. You can see that in all cases where the albuminuria is high, your chances of having end-stage renal disease, cardiovascular mortality, or all-cause mortality increases significantly. So albuminuria is incredibly important to understand to spot the health and severity within a patient. Cardiovascular events are more common in people with albuminuria, but they are less likely to occur if we can control albuminuria. We can reduce the risk. So two graphs here, this from a study by the renal group, the renal trial. It's about 1,500 patients in the Netherlands. What you can see here is that where albuminuria was increased, the hazard ratio increased, and yet when it was controlled, and in this instance they used a drug, losartan, they're able to reduce the cardiovascular risk within that patient cohort. So just to summarize here, CKD is asymptomatic. It's asymptomatic, which means that there are 1.4 million people out there who are undiagnosed, walking around with CKD, potentially doing damage to their kidneys. You need an ACR test to really understand the severity of the risk. And CVD and CKD are inherently related. If we can reduce the albuminuria, we can control the issue, we can help the patient, we can save the patient. Really important we understand that. So given all of that, why is ACR testing adherence so poor in the NHS? There's clear guidance, but there is very low compliance. On the right here, we have the national uptake of testing across the 8 care processes for diabetes. And you can see that there's one clear outlier that we've highlighted there. It's the ACR test, your urine albumin test. It is a significant outlier when it comes to adherence, and that means that a number of patients are out there walking around, still continuing to cause some damage to their kidneys. So why is that? What's stopping people from undertaking the test? And it's a combination of factors. We have clinician factors. Is there enough education out there around the importance of ACR testing? It's not routinely done as part of the annual test, and we've seen that within the National Diabetes Audit data there. But it's also patient factors. How easy is it to get a ACR test done? And if you think about it, traditionally this method has involved going to a GP practice, picking up a pot, taking a pot home, peeing in a pot, taking a pot of urine into the GP practice. It's relatively unpleasant. It's not what people want to do. And think about the time constraints around that as well. Do I have to take time off work to go and to have my GP appointment? Do I have to travel? And do I have to pay for travel to get to that GP? All of these are kind of factors that could impact the uptake of ACR testing. And what we do know from talking to our patients is that actually their understanding about the importance of an ACR test is incredibly, incredibly low. So they do not recognise the importance of the test, and they do not understand how impactful CKD could be on their lives. We do know that chronic illness is a continual chore, and that if you end up in that cycle, you're essentially going for prescriptions, appointments, and you're on for endless tests. If we can remove the chore, we know that patients will start to manage their condition better. So, what are we doing about this? In 2020, we were awarded a grant from the Accelerated Access Collaborative, and it was to get to 635,000 untested patients, so those in the underserved communities with diabetes and hypertension. We rolled out this kit here, which is Meaningful Kidney Kit. You can see it's designed to fit through any letterbox in the land. And this arrived on the doorsteps of those patients, and essentially they start to complete the kit in the comfort of their own home. Here's a little, I wonder if I can click on that just to show you a quick, I can. It's a little example of the unboxing and the testing. Really simple. It's the same test to be undertaken in GP practice, but it's all handled via the smartphone. So we are the first company in the world to turn the smartphone into a medical grade device. Essentially, we're talking about population screening here. So we're given a cohort. We work with the ICBs to define a cohort of patients that are at risk. We send them a meaningful kidney test, and you're supported in that through an app, through a smartphone app, where our avatar Emily, who has a usability of 99.5% from 18 to 80-year-olds, helps you to complete the test. You're also supported by an in-house call centre that we have, and so they're available for any inbound or outbound calls. They're able to speak 9 different languages so far across our team, and they help you to complete the test. Once the test is completed in the comfort of their own home, the patient gets a result, and that result is also integrated into the GP system, so instantaneous result into EMIS and System 1. And you're categorised via a semi-quantitative result into either A1, which is normal, normally means no action required, come back in a year's time. Abnormal, which implies that there's a slightly elevated protein count in your urine, which means that we do need to see you again. So in 90 days, that's nice guidance. We want to test again because we're allowing for an elevated protein level due to exercise, could be due to diet, could be due to infection. So we're kind of allowing for that. And then A3, which is high abnormal, which means it's highly likely that you have the early stages of chronic kidney disease. What have we achieved so far? So we're in 22 ICBs at present, and we've managed to get 434,000 patients to engage in their own care. Now, it's really important to understand that's 434,000 patients who have been underserved, who have been untested for periods, who have been walking around potentially asymptomatic for a period. 231,000 of those patients have completed that test in the comfort of their own home. So we've got 55% uptake, and there's still tests out there circulating, still waiting to be completed. 34% of those have been identified as having abnormal results. They may require some further attention, review. They may require some form of intervention. That's 78,000 folk that we've picked up as having abnormal results. And then 6% or 14,000 people out there have had high abnormal results. So highly likely that they might have chronic kidney disease, get reviewed by the GP. If we can optimize that patient, we can save that patient from some horrendous life outcomes. It's generally loved by all of the patients. 96% found the test easy or very easy to use. 95% didn't encounter any problems. 90% would recommend to a friend or family. And you can do it later, but if you look on Google Play or Apple, you'll see that there are 26,000 reviews espousing the virtues of the test. From a GP perspective, we've done a survey of the GPs that have used Meaningful Kidney. 82% would recommend it above the standard method of testing. Just want to take you through a few little bits of data that we started to kind of pull out from the work to date. So thanks to the National Diabetes Audit, which is collected annually, we're able to compare year on year. And so what we did here, this is a national picture. When we look at the uptake across IMD deciles, we can see that before Meaningful Kidney, there was a gap between IMD deciles 1 and 2, so the most deprived communities, and IMD deciles 3 to 10. And that gap was around 1.9%. Post-meaningful kidney, what we've found is that we've narrowed that gap quite substantially by 74%, actually. So we've taken it to almost being equal, just a 0.4% gap there now. And interestingly, across the practices that did not use meaningful kidney, the gap remained. So meaningful kidney is clearly having an impact and is helping to address some of the inequalities that exist around ACR testing. This is just looking at the... Oh, sorry. Right. Oh, right. Okay. I'll wrap up really quickly. Kent and Medway, this is just showing the uptake of meaningful kidney against the standard model of care. So you can see that we had a big uptake, and we wanted to just make sure that across the 5-year period we weren't inadvertently impacted by COVID. So you can see here that across 5 years we actually managed to bring uptake substantially above the practice not using meaningful kidney. Here's another IMD graph that just shows that the uptake in the blue line here, uptake was much greater in the lower IMD deciles, 1 to 4, so the more deprived communities. This is about the younger cohorts starting to appreciate the importance of ACR testing. You can see we've shifted the bell curve to the left. That does not mean that we're excluding the elderly from testing. In fact, just 3 weeks ago, we had a 104-year-old manage to complete the test on a smartphone under our own steam. And then finally, this is just to show that 82% of the people that we were looking at in Barking, Havering and Redbridge had never previously tested. So they were walking around asymptomatically, causing damage to their kidneys. That's it. I won't summarise, but hopefully that was useful. Thanks so much for your time.